Go ahead and start the recording.
Recording has started.
So, good morning. I'm Mike Sowell. I'm director of the headache program. Actually, this month will be 18 years ago is when I started the headache program. Most of you know me, so I won't go into too much detail on the introduction, but um, headache is what I do, and facial pain is a part of that. So, this morning we're going to talk about advances in trigeminal neuralgia. So our objective is to provide an update on the evaluation and management of trigeminal neuralgia with our outcome, hopefully to improve the management of patients with trigeminal neuralgia and improve outcomes overall. So by way of disclosure, I think none of these disclosures have anything to do with trigeminal neuralgia, but that's what I do. Off-label use, nothing is on label for trigeminal neuralgia, so that makes it easy. Um, So we're going to talk about background and some of the historic aspects. I'm just going to move this little box out of my way. Pardon me for a minute. Clinical evaluation. What are the diagnostic criteria for the most common cranial neuralgias? We're really going to pretty much emphasize trigeminal neuralgia, but I'm going to touch on some of the other cranial neuralgias. We're going to talk about the pathophysiology of trigeminal neuralgia, differential diagnosis, evaluation, and then medical options and procedural and surgical options, and then close with references. There we go. So trigeminal neuralgia is some of the background. Occasionally, I still hear the term tic douloureux, or somebody will tell me that another doctor diagnosed them with tic douloureux. Douloureux is French for pain, and tic just means paroxysm. So descriptions of facial pain date back to, really in the, very early around 1000 AD. And the idea that trigeminal neuralgia may be related to a microvascular compression was attributed to Dandy in 1934. And then in 1965, there's a guy named Peter Janetta, who passed away not too long ago, developed a subtentorial or transtentorial microsurgical procedure for the purpose of sectioning part of the trigeminal nerve, and then later that reformed into kind of placement of material between the nerve and the a blood vessel, and so that became known as a microvascular decompression. Um, Peter Janetta passed away in 2016. I just looked up. Trigeminal neuralgia is the most common form of facial pain in individuals older than 50 years of age. Has an incidence of about 4 to 5 new patients per 100,000, higher among those greater than 50 years of age, and the prevalence is about 15.5 per 100,000. Can occur at any age, onset after 40 in 90% of cases. So, young person with facial pain is an outlier. So, some of the key points: most cranial neuralgias involve the trigeminal nerve. However, sensory branches of the facial glossopharyngeal nerves and the second cervical nerve can also transmit pain, so we'll touch on those briefly. An organized clinical approach is key to reaching a correct diagnosis in patients with facial pain. And trigeminal neuralgia, again, is the most intensely painful of the cranial neuralgias. And pain of trigeminal neuralgia is paroxysmal, classically sharp, or electrical in quality. So this is the IHS classification scheme. I have several objections to the IHS classification scheme, but they didn't invite me to the conference in Italy, I think is where it was. But the this just kind of outlines, what cranial nerves can be involved with pain, which ones have sensory afferents. But the thing I don't like about the classification scheme is down here at the bottom. Why would you put occipital neuralgia and cranial neuralgias when it involves a cervical nerve, not a cranial nerve? That's mincing words. And then central neuropathic pain is, just what it says. It's central, not peripheral. So why would you say that? So I'm showing this diagram not to insult folks, but to with a kind of review of anatomy. It's V1, V2, and V3 of the trigeminal nerve, but to highlight the fact that there can be branches of the trigeminal nerve that can be affected. And so if you have, the core of what we do and what sets us apart from other specialties is that we localize disease states neuroanatomically. And so if I have somebody, for example, that has, pain in a small distribution, not involving an entire branch of the trigeminal nerve, then I am more concerned for local pathology. And so multidisciplinary collaboration with patient care with dentists, ENT surgeons, neurosurgeons, et cetera, is key in the treatment of trigeminal neuralgia or facial pain. And so we'll talk more about that. But when we're taking history, we want to answer certain questions. So when did the symptoms begin? Does the pain occur in attacks of pain? What's the duration of each attack? Do the symptoms continue between the attacks? And in the case of trigeminal neuralgia, what parts of the face is involved? So, is it V1, V2, or V3, or some combination? Or as I mentioned, is it a small segment within V1, V2, or V3, and therefore more concerning for local anatomic pathology? And then what seems to trigger the attacks? So light touch, innocuous stimuli, cold, wind, these sorts of things. And are there any autonomic symptoms? And that's how we draw the distinction between trigeminal autonomic cephalgias and trigeminal neuralgia. So the IHS classification scheme talks about painful cranial neuropathies, other facial pains, and other headaches. And it's under section 13. And what we have then is trigeminal neuralgia being 13.1, glossopharyngeal neuralgia involving the glossopharyngeal nerve is the second. And then, I sometimes see patients with these other conditions. Again, occipital neuralgia, I think, doesn't really belong. Optic neuritis, we need to be thinking about that in a person who otherwise seems to have migraine and has retroorbital pain, but then maybe we have to, that's where our exam is important, looking for an afferent pupillar defect or diminished visual acuity, things like that. And then some of these others are very uncommon. So in 18 years, I've seen one case of Rader syndrome, and that was years ago. Recurrent painful ophthalmoplegic neuropathy, some might recognize as being what used to be called ophthalmoplegic migraine. We now know that that's not migraine at all. That, in fact, that it's probably an inflammatory, infiltrative, or otherwise immune-mediated condition that affects the third nerve. A very uncommon condition, but I have patients with this, have burning mouth syndrome, which doesn't fit a neuroanatomic distribution. It's the entire inside of the mouth. And then persistent idiopathic facial pain is kind of our default diagnosis in patients in whom that are referred for trigeminal neuralgia but really don't meet the diagnostic criteria for trigeminal neuralgia. And we have to have in-depth investigations of those patients to make sure that there's not some secondary cause. But trigeminal neuralgia can be divided then into classical trigeminal neuralgia or painful trigeminal neuropathy. Classical trigeminal neuralgia then is subdivided into two forms, the purely paroxysmal form or the form that has concomitant persistent facial pain in between attacks. So you may have a patient who has paroxysms lasting seconds to maybe a couple of minutes, but then they have a persistent pain in between the attacks. And sort of textbook classification or classic description is paroxysms of pain lasting seconds to 2 minutes, occurring multiple times throughout the day. So broadly, trigeminal neuralgia is a disorder characterized by recurrent unilateral brief electric shock-like pains, abrupt onset and termination, limited to distribution of one or more divisions of the trigeminal nerve triggered by innocuous stimuli, may develop without apparent cause or be a result of another diagnosed disorder, and there may or may not be additionally persistent background facial pain of moderate intensity. So classic trigeminal neuralgia is, at least 3 attacks, unilateral facial pain fulfilling B and C. So B is 1 or more divisions of the trigeminal nerve, no radiation beyond the trigeminal distribution. And then 3 out of the following 4 characteristics recurring in paroxysms from a fraction of a second to 2 minutes. Severe intensity, electric shock-like, shooting, stabbing, sharp quality, and precipitation by innocuous stimuli to the affected side of the face. And not clinically evident neurologic deficit, not better accounted for by another ICHD3 diagnosis. So the paroxysmal form is recurrent attacks with no persistent facial pain between attacks, and then the concomitant persistent facial pain form is recurrent attacks with persistent facial pain, moderate intensity in the affected area in between attacks. So, slight distinction there. I think there's recognition of it's lumping and splitting, but essentially trigeminal neuralgia can involve persistent facial pain in between attacks. The classic trigeminal neuralgia with concomitant persistent facial pain has been referred to as atypical trigeminal neuralgia, or more recently, trigeminal neuralgia type 2. Again, just a little bit of word mincing, but it gets at the idea. Central sensitization may account for a persistent facial pain. We don't really know. Neurovascular compression on MRI is less likely to be demonstrated. And classical trigeminal neuralgia with concomitant persistent facial pain responds poorly to conservative treatment and to neurosurgical interventions, less likely to be triggered by innocuous stimuli. So we do have patients in which they don't fit the sort of classic picture of trigeminal neuralgia. And then painful trigeminal neuropathy is head and or facial pain and distribution of one or more branches of the trigeminal caused by another disorder or indicative of some neural damage, highly variable in quality and intensity according to the cause. So, I have patients that have had head or facial trauma and have painful trigeminal neuropathy. And then other painful trigeminal neuropathies is just to keep us thinking about etiologies. There can be painful trigeminal neuropathy attributed to acute herpes or post-herpetic trigeminal neuropathy. And then painful post-traumatic trigeminal neuropathy. One of my kind of oldest running patients, I think I've followed since 2003. I picked up from Dr. Bill Olson, who used to go to Campbellsville, but this patient had trigeminal neuralgia that occurred after being struck in the head loading an airplane. Her occupation was loading heavy stuff onto airplanes. So anyway, MS, of course, we need to think about. MS, you would not expect to be the more paroxysmal form, but we need to be thinking about MS and plaques and kind of taking a detailed history. Then painful trigeminal neuropathy attributed to space-occupying lesion, and we'll show some radiographic examples of that. And then attributed to other disorders, so we need to be thinking about structural anatomic pathologies with trigeminal neuralgia. And persistent idiopathic facial pain, again, a little wordsmithing, but facial or oral pain fulfilling B and C, recurring daily for at least 2 hours per day for more than 3 months. Both of the following characteristics: poorly localized, not following distribution of peripheral nerve, dull, aching, nagging quality, clinical neuroexam is normal, dental cause excluded by appropriate investigations, not accounted for by another ICHD3 diagnosis. So what's the pathophysiology of trigeminal neuralgia? Well, presumably chronic irritation of the trigeminal nerve due to compressive or inflammatory causes. Central factors certainly contribute to development of the forms, and so if you get a peripheral trigeminal neuralgia going on, then there can be sort of a secondary central pain syndrome as well. Neurovascular conflict involves proximal portions of the trigeminal root, the so-called root entry zone. So you'll see REZ in the literature as root entry zone. And compression probably causes this mechanical twisting of the fibers and secondary demyelination, probably mediated by ischemic injury. And these changes then can lower the excitability threshold and promote an inappropriate ephaptic propagation toward the adjacent fibers. And this crosstalk, tactile signals from the fast A beta fibers then directly activate the slow A delta fibers and produce this high frequency discharge responsible for the lightning or sharp pain triggered by tactile stimuli. So this is a interesting slide in the sense of study looking at how frequently is the pain in the various distributions of the face. So the most common is V2 and V3 combined, and then equally or near equally common is V2 or V3 only, or V1 plus V2 or V1 plus V2 plus V3. But V1 only is very much an outlier to have that and really call it trigeminal neuralgia. So when I see a patient that has just forehead pain, for example, on one side, then I have to be thinking about, in depth about structural and other anatomic causes. It's kind of a busy slide for so early in the morning, but this is a differential diagnostic consideration. So basically looking at other known headache or facial pain conditions or dental problems that have similar characteristics to trigeminal neuralgia but are in the differential. So there are some distinguishing characteristics in terms of the character of the pain, site or radiation, severity, duration, periodicity, provoking factors or relieving factors, or associated symptoms, signs, or other factors. And then we have to think about the differential diagnosis in terms of structural or secondary causes. So in classical trigeminal neuralgia, we're always thinking about the neurovascular compression of the trigeminal root or root entry zone. But with symptomatic trigeminal neuralgia, you need to think about MS, meningiomas, vestibular schwannomas, epidermoid tumors, pontine infarction, AVM, cavernous malformations, connective tissue disorders, METs, glioblastoma, other tumors, and then rarely Dandy-Walker or other craniovertebral junction disorders, and Perry-Romberg syndrome. I do have a patient that has trigeminal neuralgia and has Perry-Romberg syndrome. Perry-Romberg syndrome is a degenerative condition involving the connective and subcutaneous and structural tissues of the head and neck, and it's a progressive atrophy. This lady's had multiple kind of sinus surgeries, and to the point where there's almost no structure. So suspicious features are things like abnormal neuroexam, abnormal oral, dental, or ear exam, age of onset younger than age 40, that's pretty uncommon. Bilateral symptoms, so we have to think about MS in that particular condition, situation. Dizziness or vertigo, hearing loss or abnormalities, numbness, pain episodes persisting longer than 2 minutes, pain outside of the trigeminal nerve distribution, and or visual or other kind of neighborhood problems. So potential origins of the aberrant vascular loop in trigeminal neuralgia. The most common is the superior cerebellar artery, but you can have ICA or pica or some combo of ICA-pica. And then vertebral, vascular, and then rarely a venous structure can be the offending agent. There is a pulsatile flow to the venous system as well, as we know. Imaging studies, so most commonly, and really I should probably take MRA off of here, but what I order is typically an MRI eye of the brain with and without contrast, and specify under annotation Fiesta sequences. Fiesta stands for fast imaging employing steady state acquisition. It's essentially a heavily T2 weighted image that allows us to draw the distinction between a blood vessel and the adjacent trigeminal root entry zone. So this is a highly schematic diagram of where we're interested in looking for pathology, but essentially the root entry point in this particular paradigm is the same as root entry zone, but there's a transition zone, and then the porous trigeminus is where the nerve root enters from close to the trigeminal ganglion. So there is a point where you can have a neurovascular conflict, and this is what we're most interested in looking at our imaging studies. So I'm just going to show a few imaging studies, some of which are Fiesta and some of which are just T2 weighted imaging or T1 with contrast. But this is the first is an example of a large epidermoid cyst in the prepontine cistern. So most often, if somebody has structural pathology, then their symptoms are not don't totally meet the definition of trigeminal neuralgia. This is a high-grade neurovascular conflict. Again, neuroradiology has helped us out with the arrows here, but a heavy T2 weighted image shows a high conflict of the superior stellar artery. Just kind of helps us to look at the anatomy and draw the distinctions between the vessels and the arteries. Here's a few other images. So various causes, superior cerebellar, and then on the right, that's actually at B is the basal, I believe, that's ataxic and has an upward displacement. That's pretty uncommon that the basilar can contact the trigeminal, but it does happen sometimes. And then on the right is an aberrant venous structure. So it's most commonly to be an arterial structure, but rarely it can be a venous structure. And then this is a patient with a AVM. So at the top left is just MRI, and the top right is a standard conventional angiogram. And then I think the bottom is, I believe, a meningioma. Sorry, adjacent to the trigeminal root entry zone. Again, this is arterial conflict adjacent to the root entry zone of the trigeminal. Similar thing here, just a couple of other pictures. But medical options, it's estimated that more than 80% of patients respond initially to medical treatment. And we don't have a good explanation for this, but as time passes, medications may lose their efficacy, even if they are on multiple therapies. So what's not, I'll say, well written or well standardized is, when do you send the patients to have either a procedure or a surgical option? And I think that I tend to stick with, two different medications, and that's kind of about it. But if there's a structural anatomic adjacent blood vessel on their Fiesta, then I go ahead and invoke neurosurgery. If there is, sometimes if they fail to respond at all, even early on, then I'll go ahead and have them consult with both neurosurgery and with radiation oncology. So we have a very close collaborative situation here at UofL, which is a very nice place to practice. So Most medications have anti-epileptic activity or affect central brain transmission, so that's the case of baclofen. This is a just kind of summary slide. 2014, Paul Gadiant was a student here, went on to UK, unfortunately for neurology residency, and then did a vascular neurology fellowship and is now in Florida. But and then he and Jonathan Smith, who's now at Mayo, Scottsdale, I believe, kind of summarized the medications that we use. So typically carbamazepine. So I, undoubtedly do things because I'm from the old school, but carbamazepine is less likely to cause hyponatremia in this population. And so I start with good old-fashioned carbamazepine, approved in 1982, I believe. There are studies that compare oxcarbazepine to carbamazepine, and basically the efficacy is thought to be the same. The complication or the side effect or complication rate's a little bit higher with oxcarb. Gabapentin is sometimes used, pregabalin, lamotrigine, topiramate, baclofen, and less commonly amitriptyline. So procedural and surgical options, I'm just going to touch base on. These are reserved for patients who failed to achieve pain relief after adequate trials of 2 or 3 medications, or when pain relief is attained but patient is experiencing significant drug toxicity, or in the presence of a symptomatic trigeminal neuralgia with a surgically amenable structural lesion. So we're fortunate to have the advancement of Fiesta sequences and be able to identify those patients early when they're still healthy enough for microvascular decompression. But these are the various options or choices. So microvascular decompression, stereotactic radius surgery, either CyberKnife or Gamma Knife, and then other procedures, percutaneous radiofrequency rhizotomy, balloon microcompression, glycerol rhizolysis, and trigeminal rhizotomy are sometimes used. I'm really going to touch base on the first two, basically microvascular decompression and stereotactic radius surgery. So microvascular decompression is a retromastoid craniotomy approach, exploration of the pontocerebellar area, and then if there's a vessel identified compressing or contacting fifth cranial nerve, particularly the root entry zone or root entry point, then a decompression is performed using muscle or some other substance placed in between the offending vessel and the nerve, and tacked down in some way to keep it from shifting. Stereotactic radius surgery. This is kind of the extent of my knowledge of radiation oncology, but that's kind of what a CyberKnife unit looks like. There's a frame and radioactive cobalt source, and then radiation and a target. And this is done in a much more precise fashion than I have knowledge of or could demonstrate. But I think this is a pretty good paper. This is a meta-analysis. So the difference between a systematic review and a meta-analysis is meta-analysis has much more rigorous criteria, and this is published in 2017 from World Neurosurgery. Looked at 53 studies that met criteria over 13,000 patients and compared microvascular decompression to stereotactic radius surgery and looked at outcomes. So these are a little bit small print and busy slides, but kind of looking at how they pulled the literature and came up with their number of studies. And this is just a listing of the studies and where they, as you can see, the majority were retrospective. And this is demographic information on the patients. They use the Barrow Neurologic Institute pain score. I don't necessarily find this useful for one patient and one headache specialist following patients, but I think it's useful in patients who, are going up for a procedure, either the stereotactic radius surgery or microvascular decompression, to kind of classify them according to their response to medication or to a procedure. And you can see that this is kind of a gross sort of characterization of their benefit. So in the group treated with radiosurgery, the initial success rate was about 71.1%. Success rates at follow-up 2 years, between 2 and 5 years, and then after 5 years were 77, 63, and 63.8% respectively. So a slight decrement after 5 years. And then in the group treated with microvascular decompression, the initial success rate was 86.9%, so a higher success rate, and then follow-up at strangely higher at 2 years at 91%, 80%, and then 84% respectively. So overall, if the patient is healthy enough, and there are anesthesia rating scales that I am not going to go into, but if the patient has multiple other medical conditions, they may not be healthy enough to have a microvascular decompression, and the risk-benefit ratio may be outweighed. But generally speaking, in particular, if you find a neurovascular conflict on imaging, then those are the patients that are referred to neurosurgery for the microvascular decompression. Complication rate, however, is a little bit higher for microvascular decompression than radiosurgery, and some maybe less expected things like hearing loss or dysesthesias. And this is another look at the complication rate. The microvascular decompression is the darker orange. I'm not sure how I chose these colors, but the lighter orange is radiosurgery. And then, as you can see, there's some risk of CSF leak, infections, some sort of cerebrovascular event, anesthesia-related complications, and other that make the complication rate, at some centers as high as 3.5%. I think we have a much lower complication rate here. Recurrence rates, higher for the radiosurgery than for the microvascular decompression. So this is just a look at, and really this is just a screenshot from clinicaltrials.gov looking at various types of ongoing trials. I can tell you that Botox is not effective for trigeminal neuralgia. I get that question a lot, but it's unfortunately just not effective. There have been some, most of the trials that are ongoing are looking at different dosages or techniques for radiosurgery. Some have to do with particular surgical techniques for microvascular decompression. But intriguingly, there has been ongoing trials of the monoclonal antibodies to CGRP, but very little published data. I think maybe some single case studies here and there, but not larger scale prospective randomized controlled trials of the monoclonal antibodies yet to CGRP, but maybe hold some promise. We just don't have any results yet. I think that's all I have, and I, would invite everybody to unmute or turn on video or whatever, and have questions or discussions or any other aspects that I haven't covered. I'd be glad to answer any questions.
Dr. Sowell, I have a question. Can you hear me?
Yes, ma'am. Yes, ma'am.
I have a patient who was admitted to the hospital, definitely didn't meet kind of classic criteria for trigeminal neuralgia, but treated as a headache phenomenon. He had some visual changes, and then he did kind of have some unilateral facial pain, but it wasn't classic necessarily. But the pain And then he went home and he's continued to have just this persistent numbness, kind of initially in a V1, V2 distribution, but now it's really just V1. And otherwise, his exam is totally normal, and his MRI and vessel imaging is totally normal. Is loss of sensation something that you ever see as like a post headache, like residual? I mean, is that something that you ever see, or does that just raise the question for something completely different?
I don't see that very commonly. I think certainly raises the question for something different. I think merits kind of more in-depth investigation. And this is an adult.
He's a teenager.
Okay. Um, Certainly, that's somebody I would be sort of thinking about. Uh, Getting ENT to do more in-depth head and neck exam, and I'm sure he's had kind of routine imaging. Um,
Yeah, I didn't know about the Fiesta protocol, so I didn't order that, but he had just a regular MRI and MRA.
yeah, and typically the MRI at Children's is pretty good. So the Fiesta is just a slight augmentation, I guess, of the T2, heavily T2 weighted image. Um, but yeah, I'm blanking on thoughts, but that's um, I'd be glad to see him if I can help in any way. But no, that's certainly an outlier to have
Okay.
persistent numbness in the V1. Yeah.
All right. Thank you.
Dr. Sowell, this is Rivaj. I have one question.
Yes, sir.
There is a there is an evolving theory right now, like for the migraine headache, the origin is also a trigeminal nerve, and for the case of the classic trigeminal neuralgia, where we don't find any structural abnormality, is there overlap between those trigeminal neuralgia and the migraine headache?
Yeah. So my it's a good question. So trigeminal neuralgia and migraine are in overlapping distributions neuroanatomically, but that's certainly probably the genesis of why we're even trying monoclonal antibodies to CGRP, for trigeminal neuralgia. Um, the but so there are similarities, but the main difference, it has to do with the neuropathic pain, and its response mostly to kind of sodium channel anticonvulsants, and we know that those don't work right for prevention of migraine.
Mhm.
So there are some clear differences that are probably at this point not well elucidated. Um, but yeah, that's a good question.
Interesting. And likewise, I think the medication that we use in migraine, like that of Topomax and propanolol, could be ineffective in trigeminal neuralgia. Is that a case, or hasn't it been tried in the past about these medications?
So I don't know that propranolol has ever been tried, and propranolol, I find, I'm always trying to find answers. Propranolol, I find to be a frustrating drug in the sense that explanations given for how it works are, in my mind, kind of lame. So things like disruption of nociceptive circuits, well, that's kind of circular logic to me. Of course, it disrupts nociceptive circuits. I mean, eventually you're talking about, just because you're translating to Latin, nociception means pain. I'm not fooled by that one. So, but Topamax, yeah, I don't think that it, um, I'm not sure of systematic study for trigeminal neuralgia. I don't think I've seen any systematic studies of that. Topamax is an interesting drug in the sense that it's relatively broad spectrum, multiple mechanisms of action. Um, off the top of my head, I don't know if it works on sodium channel, but it works on so many other neurotransmitters. But yeah, I don't like. Essentially, I don't know that I've ever prescribed Topamax for trigeminal neuralgia, but it's a good question. So I think we need to draw the distinctions kind of up front on historic grounds. Uh, in today's with our current knowledge base, and ask the questions about noxious stimuli and get kind of a image in our mind of what the pain pattern is. And the patients with trigeminal neuralgia don't have autonomic symptoms. And you do find autonomic symptoms sometimes with migraine, like this, presumably the sensitivity to light and sound are autonomic in nature. Um, so yeah, there are some similarities, but I think we need to draw the distinctions on historic grounds as much as anything.
Sure. Thank you very much.
All right. Well, I guess if no other questions, I thank everybody very much for tuning in.